Now let us start our discussion of part 2 of Doppler and Rh negative pregnancy. So mainly now we are going to focus on Rh negative pregnancy. So what is Rh negative pregnancy? Let us find out. In that, first thing you need to see is Rh antigens. Okay, so what are Rh antigens? You have mainly different types of antigens like small c antigen, capital C antigen, capital D antigen, capital E antigen, small e antigen. So these are the different antigens of Rh, Rh antigens. Among this, the most powerful and the most important antigen which we want is the D antigen. So the D antigen is the most powerful antigen. Okay, so if D antigen is present, then you will say that is Rh positive, and if the D antigen is absent, then you will say it is Rh negative. Okay, and this antigen is present on the short arm of chromosome 1. Okay, so Rh antigen, important antigen is D. If it is present, Rh positive. If it is absent, Rh negative. And it is present on the short arm of chromosome 1. And this is discovered by scientists called as Land, Steiner and Weiner. Okay, Land, Steiner and Weiner. So now coming to Rh negative pregnancy, what is going on here? Now let us understand the process. So first coming to the mother. Here the mother is Rh negative. Okay. So we are saying Rh negative pregnancy means we are mainly typically presenting about mother. Mother is Rh negative here. So for example, let us draw this as mother RBC which are negative. And here there is an Rh antigen which is actually present on fetal cells, and here the fetus is Rh positive. Fetus is Rh positive, mother is Rh negative. That is the problem. So actually what happens is here the Rh positive fetus which is entering the maternal circulation by means of placenta, by means of any rupture or hemorrhage. So in this case what happens is the Rh antigen which is present on the fetus is activating the mother Rh negative to form an antibody. So it is stimulating the maternal immune system to produce an antibody against this, and that antibody is Rh antibody, also called as anti-D antibody. Okay, so now this antibody is able to form IgM. IgM is the type which doesn't cross the placenta. This IgM converts later into IgG. This IgG can cross the placenta, but this conversion needs at least 6 months. So at least 6 months are required to convert from IgM to IgG. Okay, and if this IgG is formed, it can cross the placenta. Then what happens? If it crosses the placenta, it will lead to antigen antibody reaction which is going on. So because of this, which is going on in the fetus, so because of this there is fetal hemolysis. All the blood cells in the fetus will undergo lysis, and that is leading to severe fetal anemia, and the severe fetal anemia will in turn lead to fetal edema, because anemia means all the red blood cell are clustered and they're all cut off. Now all the fluid which is present in the blood vessels will come out, will leak out and lead to edema, so fetal edema. So the Rh isoimmunized reaction is what is called this one. So now let's see what is the Rh isoimmunized reaction. So I hope you understood this process. Okay, so Rh isoimmunized reaction, what is this? Let us see. In this reaction there is hemolysis in the fetus, first step as we know. Okay, hemolysis in fetus, and because of this what is all going to happen? So first thing what is going to happen is fetal anemia. So anemia, so fetal anemia, because of this there is sinusoidal heart rate pattern. You will see sinusoidal heart rate pattern, and the next one which you see is peak systolic velocity increase in the middle cerebral artery. Just now we have seen in the part 1 that in the middle cerebral artery Doppler, whenever the peak systolic velocity increases, it indicates that is a anemia, right? Or you can say whenever the middle I know that mom value is greater than 1.5, you can say confirm as fetal anemia, right? And the next one is because of hemolysis in fetus, there is rise in bilirubin levels. So whenever there is rise in bilirubin level, it will lead to jaundice, and that is a golden yellow amniotic fluid, which will form a golden yellow amniotic fluid. And the other thing is, if bilirubin is greater than 20 milligrams per dl, it will lead to kernicterus. So because of bilirubin, there are two problems. One is jaundice, that is causing golden yellow amniotic fluid, and another problem is if the bilirubin is greater than 20 milligrams per dl, it will lead to kernicterus. Okay, and this golden yellow amniotic fluid is a collection of fluid, especially in a interstitial space. That is, either it can be in a pericardium, you will see in pericardium also golden color yellow fluid, even in pleural effusion you will see, and even ascites around the liver. So you will see this golden yellow color in all these places because of increase in bilirubin in fetus. So there's another one, that is Hepato Splenomegaly. So both the spleen and liver will undergo megaly. They become big in size, and even there is bone marrow hyperplasia. Okay, because of this there is more erythrocytes. Why there are erythrocytes? Because now you can see in the fetus almost all the blood cells are undergone hemolysis, means all of them are breakdown. Now what fetus want to do is it wanted to increase the erythrocytes in it. So in attempt to increase the erythrocyte, spleen will undergo megaly, hepatomegaly, splenomegaly, bone marrow hyperplasia. So because of all this, because these are the three sites of blood production, right? So they will undergo hyperplasia, or you can say megaly. So they produce more erythrocytes, and that's why, as it is producing more erythrocytes, this whole condition, this whole Rh immunization reaction is called as erythroblastosis. Erythroblastosis, we are calling blastosis because here all organs are undergoing megaly. Erythroblastosis fetalis, this whole process is in the fetus, right? So that's why erythroblastosis fetalis. So if this immunization reaction takes place, then this is what happens in the fetus. And hemolysis in fetus will also lead to placentomegaly. Even the placenta will undergo megaly, that even the placenta will become big, and because of placenta has become big, there is increased blood supply to fetus from the placenta. So now more blood is coming from the placenta to the fetus. So this is leading to PIH in mother. In mother, the PIH. So because of Rh isoimmunization, not only in the fetus there are problems, even in the mother there is problem because of placentomegaly. More blood is coming from the placenta to the fetus. So in the mother there is hypertension. There is pregnancy induced hypertension. So what are the fetal manifestations which we see in this process? Let us check out. So now let us write the fetal manifestations. Like you have fetal anemia because all the blood cells are undergoing lysis, and there is also icterus gravis neonatarum. Okay, icterus gravis neonatarum, and other one is hydrops fetalis. All these conditions are associated in the fetus because of Rh negative immunization. So this is also called as hydrops fetalis, also called as grave or worst prognosis. Actually this is a worst prognosis, that because of this hydrops fetalis in the Rh negative mother, we are going to even terminate the pregnancy because of this hydrops fetalis, because there is a worst prognosis in this case. So what are the manifestations in the mother because of this Rh isoimmunization reaction is in the mother? Okay, that is PIH because placentomegaly, and also polyhydramnios because more blood is needed to supply, so there will be more renal blood flow, more GFR, more urine, so more amniotic fluid. So now coming to Rh negative pregnancy concepts, let us understand the concepts of Rh negative pregnancy now. So the concepts are, the first one is Rh negative pregnancy is a problem only if the mother is Rh negative and fetus is Rh positive. Okay, so if both mother and fetus are Rh negative, then no problem, of course. Hence the first investigation to be done when a pregnant Rh negative female comes is always check the Rh status of husband. So we need to check the Rh status of husband, because here what are the cases? If the Rh negative, if the husband is Rh negative, then 100% fetus also is Rh negative. Okay, and if the husband is Rh positive, then there is a 50% chance for the fetus to be Rh positive. So this is the case first we need to do. And next, coming to the problem which arises due to mixing of fetal blood with maternal blood. So if fetal blood and maternal blood are mixing, this is leading to a problem like as little as 0.1. Even 0.1 ml of maternal blood is mixing with fetal blood, then it is leading to this Rh reaction problem. That is, even 0.1 ml of fetus blood is going to maternal blood, there is this antigen antibody reaction and causing all the erythroblastosis fetalis problem. So the problem arises when mother immune system forms Rh antibodies against the fetus antigen, right? So which can cross the placenta, that is IgG. So therefore the first pregnancy is safe. So what you need to say is, in the first pregnancy, only IgM will be present and IgG is still not formed. As still IgG is not formed, as you know, it takes 6 months to convert from IgM to IgG. In the first pregnancy, already if the baby is Rh positive and the mother is Rh negative, it's a normal pregnancy because still IgG is not formed and it is not crossing placenta and there is no this reaction. But in the next pregnancy, again this Rh negative female may have a chance because now the IgG is ready and it may easily destroy the fetus. Okay, so what we need to do? The role of anti-D. What is anti-D? Anti-D, it should be given in Rh negative female. If Rh negative pregnant female has been given anti-D, that is like about 300 micrograms of anti-D beforehand, then what happens? This anti-D neutralizes the 15 ml of fetal RBC. So what it does is actually the maternal already, you know, the blood which is mixing, the fetus blood which is mixing with the maternal blood, if you give anti-D, instead it will not mix with the maternal blood, but it will act with the anti-D. So because of this, what happens is the 300 micrograms of anti-D neutralize 15 ml of fetal blood. So the fetal RBC enters the mother circulation, and fetal RBC with Rh antigen bind with anti-D in mother's blood. So antigen antibody interaction will take place and the fetal blood cells are hemolyzed even before they could stimulate mother immune system. So now you can see, as this process is going on, only this anti-D and 50 ml of RBC will get hemolyzed and there is no activation of mother's immune system. So if mother immune system is not activated, then there is no problem, right? So mother immune system doesn't form Rh antibody. So if mother immune system will not form Rh antibody, then no fetal hemolysis. So this is how we use the anti-D antibodies. So anti-D should be given before fetal RBC stimulating the mother immune system. So for this, how we'll understand whether the immune system is activated or not in the mother. So we need to do indirect comb test in the mother. So for the mother, you need to do indirect comb test for the mother blood. So if the mother blood says it is negative, it is positive, what it is. If it is negative, then the mother immune system is not stimulated. So here the immune system is still not stimulated and not yet stabilized. But if it is positive, then already stimulated, so it will produce already stimulated, so it will produce anti-D here. Okay, so I hope this is clear. So now if it is already stimulated, then it will produce anti-D. So by this we completed this one. Next we'll start with the other one, that is Rh negative cases.